Welcome back to Untold Physio Stories podcast. I'm your host, Dr. E. My co-host, Dr. Sean Wells, is somewhere surfing in New Zealand as we speak. But I have a very special guest, one of my research heroes, Dr. Peter Malliaras. Right? Is that how you say your last name?
That is absolutely right. Yep, Urson, that is correct. That is
I've been
correct.
studying. Yeah, I've been practicing. I've been also saying it wrong all of these years. I've been talking about your tendinopathy research in your courses, and I've
Yeah,
been mispronouncing it, but I guess you've been mispronouncing my last name too. I don't know if that
yeah,
ever comes
quite
out of your mouth,
possibly.
but yeah. So
Quite
you want to give a
possibly.
little background, and then I think you have an interesting story that led you to a recently published piece of research.
Yeah, look, do you want me to give some background about myself to start with?
Yeah, sure.
Yeah, so basically, I am a physiotherapist, PT. I work in Melbourne, Australia. I have been practicing now for just over 25 years, and a lot of that time I've been doing research as well. So I work at the moment at a university called Monash University full time, but then I also see patients at a place which is local to the university, and it's a really cool facility. They do a lot of ACL rehab and a lot of high end rehab there. So I work there seeing patients, and we've also got PhD students that come through and do some studies there as well. So that's sort of the mix at the moment in terms of what I'm doing.
All right. How did you become interested in tendinopathy?
Um, I guess I was a young physiotherapist, and I was really keen to learn and just exploring different avenues and different things. And then to be honest, it was just really serendipity. I just was working with some people who were very interested in that area as well, and then I just got interested in tendon patients from that. So it wasn't there, and it was just seeing people with those types of conditions. But then after I started seeing people with tendinopathy, then I really got interested in learning more and more about tendons, and I just found them, fascinating from then on.
Yeah, I mean, if you had started your brand 20 years ago, that would have been called tendonitis rehab, and then you would have had to change it.
It would have, yeah,
Yeah.
it would have.
So let's talk about what led you to do this most recent study, which is why I reached out to you because I was just about to get a Shockwave machine until I actually read your study. So tell me what led up to this, and even in terms of you using it for about 10 years, and then the study happened. What happened?
Yeah, so basically I was in London, and I was working in London, and I first started using Shockwave when I was there, and I think it was about would have been about 2010, so around about that time, and I started using Shockwave, and back then it was very new, and everyone was really excited about it because they thought there was a few studies that had come out in the mid 2000s, and they were showing that it was quite positive, the effects of shockwave. So people were quite excited about it. And so we started using it in the clinic, and we were sort of getting mixed, results. Well, some patients were improving, other patients were not improving. And we were thinking maybe there is something that is beneficial with shockwave. So then I kept using it, and when I came to Australia, one of the things that I bought with me was a shockwave machine from the UK, one that I bought over there. So that was shipped over, and um, basically I kept using it in the clinic, and then
When you say
at
you
some
kept using it, were you saying on every tendinopathy patient or every MSK patient, or what were your, what were the
yeah, look,
what were your indications?
yeah, I was using it really as an adjunct. So if someone was not showing signs of improvement with rehabilitation initially, then I would add in the shockwave, and that would be an adjunct to what I was doing. So it was an adjunct to exercise, and that's how I'd use it. So then it sort of led me to think, okay, I want to test this a bit more. So I want to do a randomized trial to test this and see if it actually works. And I started digging into the literature a little bit, and there's been a number of really high quality systematic reviews. Probably one of the best ones is the BJSM one from Korakakis, the surname is, and that was published, I think, in 2018. And that was the first one to show that maybe shockwave isn't as good as what we thought initially. There are some holes in the shockwave research. So then I started looking into that further, and we designed a trial. And the trial was going to be a placebo controlled trial. So we're going to compare shockwave to placebo sham. And that trial started with a PhD student in 2020. And he collected all the data over 2021, 22, and then finally we got around to analysing the results over the last couple of years. And the paper was completed sometime, well, probably early 2024, and then submitted and accepted last year. So what we did in that. So that was sort of what led me to to do that trial. What we did was try and design a trial that was as high quality as possible, looking at shockwave therapy versus a placebo or a sham. I did it exactly as I would do it in clinical practice. So I used the same sort of dosage, and we did also very high quality exercise alongside the shockwave. So people got exercise and they also got shockwave, and they were randomized. The difference between the groups was whether people did real shockwave or the sham shockwave. And we went to great lengths to make sure the sham shockwave was going to be really, really convincing. Because
So it still had the clicking or
everything,
yeah.
everything. Yeah. So we got the same machine. We got the same applicator. We standardized the noise that the machine made. We standardized all the instructions to the patient, so the patients heard exactly the same
Mm.
instructions. We standardized the time of the treatment, the preparation, just absolutely everything. Which is really what you need to do in a placebo trial, because you need to make sure that that environment is replicated. So we did all that.
The same rater as well, like the same clinician was doing the sham
We
and the
actually had 3 trained clinicians, and
okay.
they delivered the shockwave for both groups.
Okay.
So they did the shockwave for both groups. So that was equalized across both groups, because they did both similar types of shockwave in both groups. Um, so so we ended up collecting all the data. We got the data, and then we and I as a shockwave user, I was thinking to myself, maybe this is going to work. Maybe this there's going to be something in it. And we looked over 3 months. We did 3 sessions of shockwave, and we did it over 3 months, and we found pretty much no effect whatsoever for the shockwave therapy, which was surprising. But now that I reflect back on it, I was probably a clinician, and clinicians. It's interesting. Since publishing the publication, there's been huge interest in the paper online.
I bet.
'Cause,
I'm
yeah,
sure. I'm sure. Sure, it upset a lot of people.
it did. Yeah, the shockwave
Yeah.
community has come out and really thought, this can't be right. It does work when I use it in clinic, so it must work. And that's how I was thinking. I was using
Equipoise
it.
works, right?
Yeah, exactly. I've seen it work, so it must work.
Yeah.
So, um, so it's caused a change in my practice. So I've now reflected on my practice and stopped using Shockwave. And I was using it, and I always used to say to patients, look, the exercise and the active approaches are 90%, and The shockwave and the adjuncts, that's probably going to give you a further 10%, or it's going to help a little bit to get us to where we need to be. So it was never a focus of the treatment, but it was a part of the treatment. And now
Right.
it's just taken out
M-
completely.
More like a spice. It's just like
Yeah,
the way
yeah,
that
exactly.
the way that I even say manual therapy is just a passive therapy to enhance your active therapy, and it's not a fix. And that's
Yeah.
exactly the question that I asked you. I said, "Oh, do you think it's essentially just
Hmm.
like a manual therapy non-specific effect as opposed to having some sort of structural effect about somehow, I don't know, what else could we possibly have thought it was doing anyway? I mean, we know
Yeah.
that any kind
Yeah.
of true tissue adaptation does not happen rapidly, and anytime you change pain rapidly, it has to be a modulation of pain and not a change in structure. Because change in structure, the only thing that happens when structure changes quickly is rupture. Or
Yeah.
potentially, I guess, maybe if something is deranged and it is one of the few areas that can actually be reduced on its own, maybe it
Yeah.
could be a derangement and a reduction. But everywhere else,
Yeah.
especially when it comes to soft tissues, you can't change soft tissues quickly anymore. You can change joint capsular fascia or bone quickly. So,
Yeah.
um, yeah, I mean,
Yeah.
I
No,
even say the same thing
exactly.
about exercise.
Exactly right.
Helps,
Yeah. No,
if exercise
I
helps
think,
modulate pain quickly, it's not because of the exercise. It's just
yeah.
because of pain modulation. Because the long-term effects of exercise are what we're looking
Yes.
for, not the short-term effects.
Yes. No, no, exactly right. That's a very good way to look at it. If you really think critically about the mechanisms, they're not very plausible. So, the main mechanism of shockwave therapy is this, change in cellular activity, mechanotransduction type effect that people talk about, and there's lots of animal studies showing that that might be the case. But really, as you just said, it's not the way that we do tissue adaptation. You don't do tissue adaptation by having an applicator. You do that by loading and exercise and activity. So it's not gonna work that way. So that's probably not the mechanism. And I agree. I was probably thinking, and we've done some prior studies on this, looking at, is there a short-term pain effect of shockwave therapy, and that's what we thought might be the case, and that's probably what also led us to be using it for that amount of time. Um, so that short-term effect could be driven by some neuromodulatory type, effects. But another thing that we also did is we looked at the short-term effects, and this is not published in that trial. It's actually data that we have still got and we're writing up now for publication. So this is a separate trial, which was based around that same cohort. And what we did in that one was we got them to do a load test just before and just after every application of Shockwave, and we had 3 applications over 3 weeks. And we looked to see whether the load test improved. So this is people with Achilles pain doing a hop or doing a calf raise, which is painful, and then we checked after the shockwave immediately after. And what we found again is that there was no improvement. Well, actually, I
You
shouldn't
think there
say
was
that.
should you think at that point there should have been at least some, just even from a placebo standpoint, because of the
Yes.
just the interaction, right, and
No, no, you're right. You're right. You're
the
actually right.
expectation and
Yeah, yeah, there was improvement. The truth was there was improvement, but it was the same in both groups.
right.
So
Okay. Yes. Yes. That's what you're
yeah,
saying. There was no
yeah, yeah,
different from. So very similar
yes,
to the ultrasound studies a long time ago. I mean,
yeah,
I have 1 year of extra clinical practice on you, so I've been doing this a little bit longer. But I still remember I had already given up ultrasound by maybe 2006 to 2008. I don't remember exactly when the study came out, but someone
yeah,
did a similar study. I don't think it was
yeah,
they didn't have to control it as much as you for sound and everything, but
yeah,
the machine was
mm,
on or off because the patient can't tell if it's on
yeah,
or off, and the
yes,
outcomes were the same. So
yeah,
that's exactly what I say ISTM is, right? I mean, I promote
yeah,
ISTM, but I don't say
yeah,
we're
yeah,
breaking up tissues or anything. I just say we're
yeah,
causing different
yeah,
input, right? It's just
mm,
different input to modulate output. That's all.
yeah. No, absolutely, absolutely, yeah. It's interesting. It's I mean a lot. It's one of those mechanisms where some of it is driven by expectation. A lot of it is driven by expectation. That's what we're sort of starting to see with the evidence now that a lot of this stuff that we do has got a strong expectation effect to it.
Hmm.
We recently did another trial on heel wedges for Achilles tendinopathy. And everyone uses heel wedges because they're just so simple and easy to use, and they're cheap and accessible. And what we also found for that trial, which has just been submitted, is that it was an expectation effect as well compared to placebo.
Mm.
So we're starting to see a clear
Was
picture.
placebo what? Maybe an even and not a wedge? Was it
Yes,
all even?
exactly,
Okay.
exactly.
Okay. All
Yeah,
right.
yeah, just
Great.
a flat bit of nothing.
Hmm.
So yeah, it's interesting. We're starting to see that we can have a good pain effect in the short term, but there's a strong expectation factor to that, and that's fine. I don't think that's a problem to have expectation driving some of these effects if we can get a good short term win. Where I do have a problem is where it's Shockwave, where the machine costs $20,000. That's quite an expensive placebo.
Well, I mean, it is, and that's not even the ones I was looking at. And I'm sure because I remember seeing comments on another podcast, and people were asking you, or maybe it was the original YouTube. I think it was the original YouTube video that someone linked
Mm,
to me, and they were saying, "Well, you looked at radio only, so what do you say to that now?"
yeah, yeah.
Because that's what they're saying. Hey, these radio ones, you should be looking at 80,000. You should be using an $80,000 USD also
Mm,
focused machine, right?
mm,
So what do you say to that? I
yeah,
mean, because I can't imagine that somehow, first of all,
yeah,
that just because it costs four times as much, that
yeah.
the mechanism is now all of a sudden
Mm.
mechanotransduction is actually more accurate than expectation, right?
Well,
It wouldn't it.
there's there's a couple things to say to that. First of all, I think you're right. The mechanism still is not plausible, even though it's a more expensive machine, more power, more direct energy into the deeper tissues, which is all true based on focus shockwave. It still is a flawed mechanism where you're putting energy in a way that's not going to lead to the right cell response that you need to get those tissues stronger. That's probably the first thing. The second thing is we still need the data to show that focus shockwave is better than placebo. And I I think still the data, even in focus shockwave, is not that good. So it's not showing clearly that it's a winner when you compare it to placebo. So and it makes sense because pain is so complex, and we're looking at it with just this this sort of unidimensional machine that's going to somehow cause some effect on pain. Where I think focus shockwave can be useful, and this is where it all started, is breaking down calcium deposits in tissues. That's
Right.
and that's sort of that's where it all started. And in a way, I sort of wish, or maybe we should have just stuck to that application of shockwave. But clinicians being clinicians, and that is starved of anything that is high quality evidence that we can use on patients. We thought, okay, let's use it for all these other things. So, shockwave now is
Just like
used for,
Botox, right?
yeah, exactly.
Yeah.
Shockwave is used for pretty much everything that has got pain as one of the symptoms now.
Yeah. Yeah. It's interesting. I mean, one of the things I talk about manual therapy in my courses would be, well, what is so special about your hands or a tool or even the tool I developed? Because
Mm,
if we're really breaking things up, how could it be therapeutic? You think you would actually, if something was say so high focused in its energy
mm,
and depth penetration, why wouldn't it be traumatic?
yeah,
What makes it therapeutic versus traumatic?
yeah,
And I say the same thing about breaking
mm,
up scar tissue, which we know is impossible.
mm,
If you broke up scar tissue, what's the difference between you doing this and an inversion ankle sprain? It would still be traumatic,
yeah,
and it wouldn't feel good. It would feel bad because you're
yeah,
causing acute trauma.
yeah,
Um,
exactly,
so
yeah,
yeah, I mean, I'm
exactly,
still waiting. I've been waiting for so long because I teach manual therapy. It's so much easier to just say there are mechanical effects, but half of my initial evaluation is telling people about how there are no mechanical effects and everything. Hey, why aren't you beating me up with this tool? Why aren't you more aggressive?
yeah,
Why aren't you
mm,
pushing so hard? And well, I said, well, I spent the first 10 years of my career doing that. I used to bruise everyone. Did I
yeah,
get result? I got good results just like you got results, right? But what
yeah,
was the result is
mm,
also me telling you, oh yeah, I'm breaking up scar tissue. Then it turns out
mm,
I go lighter and lighter and lighter and lighter to the
yeah,
point where all I'm now just doing just really light, novel input, and
Yeah.
now no one is bruised, and you
Yeah.
know, people still. It's all just put it in perspective. Why
Yeah.
you could have the best delivery in
Mm.
the world,
Mm.
and you can't rub placebo all over trauma.
Yeah.
Like
No, no.
you can't change the expectation of true trauma.
Yeah. I think it's interesting because it's what you made me think of there is, do you know Reiki therapy? Have you heard of
Yeah.
Reiki therapy? Yeah, so
Yes.
Reiki therapy is where they don't put your hands, they don't put their hands on it at all. They
Yes. It
basically just
apparently can be
wave their
done over the phone. I've had patients who say they do it over the phone, and I'm like, well,
Reiki. Yeah,
yeah,
interesting. So and that's it seems like that's where your evolution of manual therapy has gone lighter and lighter and lighter to the point where you know maybe in 10 years your hands will be off. As
hey, I've said that if I could figure out a way to use the four, and it would work,
mm,
because essentially some of these things,
mm,
let's say craniosacral therapy, for example, they do
mm,
things like the V spread, and they do stuff like this, and they're realigning energy, or where you're
yeah,
essentially doing things like that. People obviously feel better, but it's expectation, right? As
yeah,
long as there's an
yeah,
expectation, it's only when there's no expectation. Like I've had people do studies using my tool, and the
mm,
patient is unaware that they come into the room and they locally
mm,
anesthetize the tissue, and
mm,
they scrape, and then the treatment group, there's some awareness, and there's no
mm,
local anesthetization, and the people, when there's no input, there's
yeah.
no change in output,
There's
right?
no change in
So
output. Yeah,
yeah,
interesting.
yeah,
Yeah, yeah, interesting. So you have to, and that goes back to the placebo that we were talking about earlier. If you don't design a placebo to feel like the real thing in some way, and it could be the noise, it could be the environment, or whatever it is, it's not going to work.
yeah,
So
yeah,
placebo, the way you design a placebo is very, very important
for sure.
for
Yeah, I
getting
mean,
that
what I think
expectation.
it should be, those chiropractic drop tables, those the tables that
Mm,
drop.
mm.
I think now, I mean, what I've always really wanted is just something that on my hands that makes a cavitation sound, so I don't have to try as hard. you know?
Yeah,
I mean, because
that's probably that.
sometimes I do this, and then my elbow cracks, and the
Yeah,
patient's
yeah.
like, "Oh, wow, that was great."
Yeah. I wonder if that's how they do placebo manipulation experiments. They probably do because
Yeah, I
they
mean,
have to.
I've been part of some of those studies, teaching in fellowship, and usually it's just some generic P to A. So
Yeah.
um,
Mm.
I don't know exactly how they do the placebo manipulation. Yeah, I'm not exactly sure.
Yeah, no, it's interesting because it's you'd have to have a really good you have to have a really good convincing placebo. It'd be hard because the patient has got some sort of expectation to feel, and that with our Shockwave trial we went to great lengths to make sure that we didn't include people who had had Shockwave before, because that then you know exactly what it feels like and how painful it is, and it wouldn't have been a good placebo for them.
But thanks so much for coming on the podcast. And I know you have courses and everything. You want to tell people about them?
Yeah, yeah, thank you. So I basically I run a website which is Tendinopathy. So www.tendinopathyrehaboneword.com. And on there I've got courses and I've got a blog and I've got some other stuff that we do, some free content. But I'm actually in the process of doing a new Achilles rupture and also a tendinopathy course. So that should be out in the next couple of months. Just putting the final touches on that content now. So, but if people want to email me questions, then all my details are on that website as well.
All right, great. Hey, um, oh, one question. This might not be even a short question. Someone had told one of my mentees had told me that there's studies, I believe they're out of Australia somewhere, where they are essentially casting fully ruptured tendons in a shortened position, and all it does is it seems to add only 1 month of rehab, and they don't actually have to be anesthetized or be surgery. Are you familiar? Are you part of those studies? Are you familiar with those studies?
Which Achilles or
I think Achilles, and
ACL?
Achilles was the main one, and I believe ACL as well.
Yeah, yeah. ACL, they're definitely, so they've got the what they call the cross bracing protocol for ACL now. in Australia, which has become really popular. And what they do is they put you in a they basically put you in a knee bent position, 90 degrees, and you walk around with one of those trolley things for like 6 weeks or 12 weeks, and the ACL
12
heals.
weeks. I
Yeah, yeah. Look, I'm not
think
sure of the
most people would
time.
opt in to have surgery.
Yeah, yeah, but it's trying to get healing in the ACL, maximize healing without surgery. Now, in the
Yeah.
Achilles, we definitely do a lot of that type of stuff in the Achilles, but in the ACL, it's a new thing, and it's been led by some people at Melbourne University. And it's still in the early days, and there's a lot of debate about it. Obviously,
Mhm.
the surgeons are very skeptical. Other people are also skeptical of whether you can get healing. But we know that some of the data shows that maybe you don't even need healing. You
Yeah,
can,
I mean, I've seen that data, right? I mean, people, first of all,
yeah,
it would be sport and activity dependent. And I know
yeah,
if you can do some hop tests, uh, then, do you even really need it? For
yeah,
sure.
exactly. And that's the
Yeah.
other question. So there's quite a few trials coming out, and I think the space will change in the next few years as these trials come out.
Yeah.
Yeah,
All right. Awesome. Hey, if you like, if you either want to, if you think this podcast is interesting or you want to tell Peter he's all wrong, please reach out on social media because I'm sure there are some people who are just convinced that they have success. But, he
yeah,
had success. I had success with beating up people. I had success with doing 45 minutes of manual therapy. I have success with doing 5 minutes of manual therapy. It's the same. It's all the same thing. And just because we say it's placebo doesn't mean that it's fake. It just means that the mechanisms are probably incorrect. So please write on.
that's a good point. It doesn't mean it doesn't work. It still does work.
It's just not for the reasons why you think,
Yeah, exactly.
and also probably for not for the reasons why you're telling the patients, which is even more important.
Yeah, yeah,
All right, yeah. Please rate Untold Physio Stories 5 stars wherever you listen to podcasts, especially Apple and Spotify, as that helps our discoverability. As always, you guys have a great day.
thanks, Justin.
Yeah, thank you, Peter. I'll talk to you
Yeah,
later.